Hi there. Good afternoon, everyone. We'll give it just a minute and then we'll get started with our webinar today. In the meantime, I'll just quickly introduce myself. I'm Jessica Rigler. I oversee population health here at AZ Blue. Okay, in the interest of time, we'll get started with some quick introductions. It's so great to see you all here today. Welcome. We're really thrilled to have you attending our October Arizona Community Grand Rounds, Protection Against Winter Respiratory Viruses, an update on the RSV, COVID, and flu vaccines. I'm really excited for this session today. It's very timely, and we've got some fantastic experts here with us as well. Before I introduce them, I'd like to extend a thank you to our partner, the NARVA Institute, who's instrumental in making the Arizona Community Grand Rounds possible, and to Mary Jo Gregory, Dr. Mark Carroll, Carla Berg, and Jennifer Pierce for making all of the behind the scenes things happen to pull off these sessions. Also, please make sure you stay to the end where we'll give you a quick preview of what we have coming up for November. Now it's my pleasure to introduce our speaker panel. I'll give an abbreviated summary of their very impressive bios. First, we'll hear from Nick Staab. Dr. Staab has served as an assistant medical director at the Maricopa County Department of Public Health since 2020. His prior experiences include being medical director of the Bureau of Epidemiology and Disease Control at the Arizona Department of Health Services and a pediatric hospitalist at Phoenix Children's Hospital. Next, I'll welcome Joel Terriquez. Dr. Terriquez is the cross-cutting medical director of the Bureau of Infectious Disease Services and the Bureau of Immunization Services with the Arizona Department of Health Services. He's an internal medicine and infectious disease specialist. And he's completed his training in internal medicine and infectious diseases at the University of Arizona College of Medicine in Tucson. Prior to this role, he served as the medical director for transmissible diseases and tuberculosis control officer for Coconino County. That was from 2015 to 2023. And finally, we're joined by Nathan Price. Dr. Price is originally from Tucson and completed his medical school and pediatrics residency training at the University of Arizona College of Medicine as well. After practicing in Iowa City, Dr. Price returned here to Tucson, and he's interested in congenital infection, coccidioidomycosis, and antimicrobial stewardship. So with that, I'd like to turn it over to our esteemed physician panel to give us an update on winter respiratory illnesses and vaccines. As a reminder for everyone participating, we'd love for you to use the Q&A function to send questions our way. Each of our panelists will provide some remarks, and then at the very end, we'll begin answering questions, so you can put your Q&A in at any time during the presentations. Dr. Staab, I'll pass it over to you first to begin. Thank you.
Great. Thank you, Jessica. I'm happy to be here with you all today. So I will get started with my perspective on the respiratory season upcoming and vaccines relevant to that season. So next slide, please. So I thought I would start with this. This was my first grader's homework last night. It was a short reading on this poor individual who's lying here in bed. She is sick and sad with the flu. If you just advance the slides one, the last question is, what is wrong with the family, with this family? And my first grader wrote, they did not get their flu shot. So clearly she hears a lot about this at home, and I was very proud of her. So next slide. So in spite of temperatures, certainly here in the Phoenix area being still well over 100, it is our fall and winter respiratory season, and in public health, we are gearing up to get a lot of communications about that, prepare for the season, really pushing individuals to go out there and get vaccinated. And so this is just a graphic from CDC. They have a lot of infographics up for all of us to use. I apologize that it seems a little blurry. I couldn't get it crisper, but this is just, I thought, a really good summary of COVID, flu, and RSV vaccines. Last year, we had a lot of new products come on the market. There's some confusion with rollout and supply. And so I think I kind of think of this as our second chance to get this right and really take advantage of all these products in order to make our communities as healthy as possible. So this is a nice summary infographic of those vaccines, who is eligible for those vaccines. And I have added here for Maricopa County, which vaccines we are offering at our county immunization clinics, as opposed to directing folks to other resources in the community. So if you advance one, so the little orange cactus there is the Maricopa County logo. So COVID-19, updated COVID-19 shots, as well as flu vaccines for all ages 6 months and older, are available at our county vaccine clinics. So if there's any questions about where those vaccines are going to be available, we're still seeing some providers offering flu and not COVID, or vice versa. And so we are trying to make sure that our immunization clinics and our and our resources that are going out into the community are carrying all those vaccines. Next slide. So these two, sorry, Jennifer, you can go back one. Let me just finish. So for RSV immunizations for infants, so there is nirsevimab or Beyfortus, which is technically a monoclonal antibody. It is available for all infants in their first RSV season. So those infants who are under a year of age entering this RSV season, they are eligible for Beyfortus. It's just one injection. Protects them throughout the season. This was one of those new products last season that we had a lot of difficulty due to supply, making sure that it got out there. This immunization is available at county vaccine clinics, as well as a variety of other locations. We know that providers, especially those who participate in the VFC or Vaccine for Children's program, are getting nirsevimab this year, and we are assured that the supply is in hand to cover those infants. Another area that we've seen kind of some limited access is in getting RSV vaccine for pregnant individuals. For a variety of reasons, these individuals are not finding this vaccine available either at the provider's office, and sometimes are running into difficulty getting it at retail pharmacy locations. So again, Maricopa County immunization clinics are providing that for individuals who are pregnant between 32 and 36 weeks gestation. It's a great opportunity for that individual to get vaccinated, and then the infant is protected from RSV after they're born from those antibodies that are passed from mom to baby. For a variety of reasons, due really to different budgets for vaccines for adults versus vaccines for children for those two federal programs, we are really encouraging folks who don't have access due to insurance coverage to individuals getting vaccinated during pregnancy to really focus on getting that immunization for those infants after they're born. So still kind of running through some sticky spots in terms of availability for these vaccines, but we are trying to make them available as possible. And then for RSV vaccines for older adults, 60 and over, we're really encouraging those folks, many of whom are covered either by their Medicare benefits or commercial insurance, to get those vaccines at retail pharmacies. Next slide. So I just wanted to briefly talk about, just as we are messaging vaccines, what are we really focusing on from a public health standpoint? We have gone through the COVID vaccination experience, which for better or for worse, kind of put some communication challenges in terms of how we talk about vaccines. What I'm really encouraging the provider community, as well as all of those who are individually choosing to be vaccinated, is to really try to re-normalize vaccination, talk to others about why you're choosing to vaccinate, why you're choosing to vaccinate your kids. There's a really good series, if any of you are familiar with your local epidemiologist or YLE, they're doing a 4-part series on kind of looking back at the COVID vaccine experience and kind of thinking about how we talk about vaccinations, again, to really encourage them and encourage the positive benefits of vaccination, making sure that we're messaging that appropriately. So there's a link there in this slide if you want to check that out. Next slide. Specifically for COVID vaccines, and as we talk about these vaccines, I think it's really important to emphasize their role in decreasing severe disease. I think the more folks are expecting that if they get a vaccine, they'll never get sick during the respiratory season, the harder time we have in public health to promote vaccination. But if we can really encourage people, get vaccinated so that you don't get severe disease, so that you're not hospitalized, so that our healthcare system can continue to provide its full range of services throughout the respiratory season. It's really what I'm focusing on as I'm going out and trying to encourage vaccination ahead of this respiratory season. Next slide. There have been a couple of good publications just in the past few weeks looking at vaccine efficacy and why we are encouraging these vaccines. This one looked at COVID-19 hospitalizations amongst infants and really what the great benefit is for pregnant individuals to be vaccinated so that their infant under 6 months is protected from COVID going into that season. So next slide. This is a really great graphic that shows what a high risk those infants are under 6 months of age. So the very high, relatively high, dark blue solid line there are infants 0 to 5 months. Again, these are hospitalizations with COVID-19, so it shows relative to other age groups, even those, the older kids here, what a higher risk they are and how much they would benefit from receiving those passive antibodies from a vaccinated pregnant person. Next slide. And the data further are just really encouraging in order to do that. So again, this is looking at hospitalizations of infants under 6 months of age. During the COVID season, October to September 22-23, there was 18% of those infants who were hospitalized had a vaccinated mother. And then this past season, 23-24, that number decreased to less than 5%. So thinking about all those infants who were hospitalized for COVID-19, if their birthing parent were immunized during pregnancy, they had a far less chance of being hospitalized for COVID-19, which is, again, what we're trying to prevent here. Next slide. Why RSV for infants? I think Dr. Price might talk a little bit more about this, but again, very high risk for infants with RSV, high rate of hospitalization and significant respiratory disease. So lots of good reasons to get them vaccinated. And this is really just a really incredible opportunity with these new products to get all infants vaccinated for RSV. Next slide. RSV vaccination, who's eligible for what? Again, is a little complicated because there are really three groups. There are older individuals, 60 and over, who are at high risk for severe disease from RSV. And then there are two ways to protect infants. One, again, is by vaccinating the pregnant person while they're still pregnant with that baby to protect them after they're born. And then there is the vaccination for the infant once they're born to protect them from RSV. If an infant is protected because their birthing parent were vaccinated during pregnancy, then they are technically not eligible to receive that immunization after birth for RSV, again, because they already have that protection. So again, we are really trying to make sure that this message is clear because I think it can get a little muddled. And we're very interested to see as we are working with payers moving forward as to how this is all going to be unraveled to make sure that they're tracking whether that infant is already protected by vaccination during pregnancy versus immunization afterwards. So again, I think there's again another resource from CDC. A lot of good infographics are available to help describe this to folks. Next slide. Again, distinguishing between the two ways that an infant can be protected by RSV versus vaccination during pregnancy versus immunization afterwards. This graphic just kind of shows those months here in North America that we're providing these products. So again, Vaccination for pregnant persons is being offered September through January to protect those babies after they're born. And then the immunization for infants against RSV, nirsevimab or Beyfortus, is typically offered October through March. Next slide. Then just one more recent study I wanted to highlight here. This is looking at how well during that first season last year we were able to get these RSV products out into the community. These were very impressive statistics to me. I don't think we reached nearly this level of coverage here locally in Maricopa County last year. Again, there are a lot of difficulties due to supply and getting these vaccines that were just newly approved by FDA last season. But again, looking at last RSV season, about 32.6% of babies born during that RSV season were covered due to vaccination during pregnancy. And an additional 44.6 were immunized after birth with nirsevimab. So again, pretty great statistics nationally. Again, I don't think we hit that hit quite that high or nearly that high here locally, but something we certainly aspire to and try to expand on this year. Next slide. And again, this is part of the same MMWR article. I'm not going to go into it in detail to give some time to the other panelists, but I think these are really important graphics to look over as providers, because I think it really highlights where we have opportunities to move in our conversations with patients to increase vaccination. And this is specific to RSV, but I think it can be used for COVID and flu alike. Just kind of shows where our patient population is still lacking information, where they want questions and where they are not getting vaccinated because there's still something missing in our communication. So I do think there is opportunity to really expand coverage in our community if we can, again, change the way we're talking about vaccinations to make it more of a positive conversation than a negative, really highlighting the opportunity to reduce severity of disease and decrease burden on our healthcare systems during this season. Next slide. Again, two of these slides, please take a look at them or pull up those MMWR articles. I think there's a lot of good information for providers going into this season in there. Next slide. And again, get a lot of questions about whether or not people should get these vaccines all at the same time. It is a proven and safe strategy. Get all these vaccinations at once. It'll improve our vaccination rates and it will improve safety and health during the season. Next slide. All right, I'm going to pause there and turn it over. Thank you.
Thank you so much, Dr. Staab. That was great. Really good information in there and good resources as a follow-up. I'll turn it over now to Dr. Terriquez to share some additional information with us from the state perspective. Please take it away.
Yeah, thank you. And thank you, Dr. Staab, for that amazing presentation. Next slide, please. So why does this matter? Why are we even here? Why are we talking about these respiratory infections? Multiple reasons. We know that these infections still significantly impact our general population. I'm not going to bore you to death with a lot of information regarding national trends, but we will talk about it a little bit. So just to reassure everyone, overall, our seasonal influenza activity remains low nationally, even though we know that sometimes there's going to be significant peaks of infection, which we usually anticipate to see around week 52 or so. CDC estimates that at least this one season, we've seen 35 million cases of illness associated with influenza, 21,000 deaths associated with this same infection. So far, we have 0.1 test positivity at week 38. We know that that changes with time. Mortality, again, remains extremely low. Next, please. So the percentage of visits, that's one of the things that we monitor. Percentage of visits associated with respiratory infections have been reported to be increased in age groups between newborns and 4 years of age. As Dr. Staab mentioned, that is a significant impact as this specific population can be associated with higher morbidity, higher mortality. We know that so far this season, we have seen 200 influenza pediatric deaths. So that is another major point of monitoring, just to kind of classify or determine how intense our influenza season is. So next slide, please. The rest of the age groups has remained stable. So for week 38, we know that we've seen, as of now, 25,423 influenza confirmed hospitalizations. As I mentioned earlier, the usual peak week for hospitalizations will be around week 52. This season, during that peak, we saw probably a rate of 8.9 per 1,000 population of hospitalizations, mostly associated with influenza A virus, followed by influenza B, but there is still some degree of potential co-infection. So there's a certain percentage of infections that have required hospitalizations associated with co-infection due to flu A and flu B, usually affecting either pediatric population or individuals with immune suppression. Out of the influenza A virus, the vast majority will be associated with H1N1. Next slide, please. So what is it that we do as Department of Health? What is it that we do for us to know these numbers, for us to prevent or to apply some interventions for us to prevent infection? So one of the major interventions that we do is surveillance. So we need to be looking for positive tests through different laboratories. We look at outpatient influenza-like illness. We do virologic surveillance, influenza-associated pediatric deaths, as well as monitor for any unusual influenza-related activity or occurrences through monitoring of emergency department visits in association with positive tests. Next slide, please. So what is going on with this three major respiratory viruses during this season? So far, we have information from week 37 and week 36, but over that past week, there were 77 laboratory confirmed cases of influenza. Overall, our influenza activity seems to be higher than the 5-season average. If we compare to the previous week, influenza has been in an increase. So far, 18% increase compared to the previous season at week 37. There has been, at least during this season, 4 pediatric deaths associated with influenza. And influenza-like illness is at least 1.6% of the overall total of outpatient visits. Next slide, please. When it comes to COVID-19, obviously we have seen more cases than influenza, but if we compare our number of cases of COVID-19 to previous years, we're definitely not as high as we were before. There has been a 25% decrease compared to the previous week, overall 43% decrease compared to the previous season during week 37. We know that the most common variant that we're still seeing is still KP1, KP2 as the most dominant variants here in Arizona. And our test positivity rate is very much comparable to what CDC has reported of around 11% or so. Next slide, please. RSV, as Dr. Staab was mentioning, even though we have seen less of a number of cases, we know that the peaks of infection can be significant, carrying significant morbidity, potential mortality for our pediatric population, as well as for older individuals that may end up hospitalized with COPD exacerbations or so. So overall, 94% decrease compared to the previous season, 25% decrease compared to the previous week, and the rate of positivity test is very much comparable to what CDC reported at 0.4%. Next slide, please. So what is virologic surveillance? Why are we doing this virologic surveillance? We obviously want to make sure that we monitor activity. We want to make sure that we determine if there's any new variant that may be affecting our population. Knowing this information will allow us to determine what the next vaccine will look like because in order for us to decide what components the next vaccine will have, we need to know the information from the previous year. We also make sure that we provide enough samples for antiviral resistance testing. We need to know that our virus will still be, when it comes to influenza A, susceptible to our go-to drugs for outpatients. Let's say we want to make sure that those are susceptible to Tamiflu or oseltamivir. It is important also for us to have that situational awareness to see if we need to pull any triggers to alert our general population regarding the spread of influenza. Obviously, we're always going to be in moderate alert, but if there's anything new, anything more severe, we need to know in order for us to communicate with our people or our community in the state of Arizona. Next slide, please. So we do specimen submission, different levels, whether that means monitoring with healthcare provider offices regarding influenza-like illness, or getting samples of positive samples of influenza by working with clinical and commercial labs. We also perform additional testing regarding the different variants or types of virus that we have circulating in the community. And then obviously, whenever we're obtaining those samples, we need to make sure that those samples are representative of the community through geography, age, and as well as disease severity. This is going to, again, help us determine what the next vaccine will look like. Next slide, please. So this is the type of information that we get. I'm not going to go over this in a lot of detail, but we want to know the virus type or subtype, whether that means H1N1 or H3N2. We need to know in order to impact the composition of the next vaccine for the following year. Most vaccines will have at least 2 A virus, 1 B virus. And also, as part of what we do when it comes to testing or virologic surveillance, we need to know that susceptibility pattern for the virus. We need to make sure that, again, those viruses will be susceptible to our go-to neuraminidase inhibitors, as well as other endonuclease inhibitors, because those are the medications that we have to use in our patients outside in the community. Next slide, please. So the 2024-2025 flu vaccine composition, again, as I mentioned, 2A virus, mostly focusing on H1N1, H3N2, as well as a V virus. That is the usual composition, and the decision regarding what viruses to use will come from that virologic surveillance. Next slide. So what comes next? Vaccination is what usually comes next. We need to make sure that we know and that we understand that COVID-19 as well as influenza vaccinations are both readily available. We know that COVID-19 vaccine will be available commercially. The coverage of this vaccine will depend on the individual insurance company. So most insurances will definitely cover for that vaccination. If for whatever reason we have someone that is underinsured or underinsured, for those eligible children, they may get the vaccine through the Vaccines for Children program. CDC has also recently allocated near $2 million for the state of Arizona, which has been distributed among different counties with the sole purpose of providing that vaccination. Vaccine for adults, even though it provides limited coverage, it will also can potentially be utilized for those individuals that are completely uninsured or underinsured. When it comes to influenza, again, mostly covered by all commercial insurances. If individuals are unable to get that vaccine, either vaccine for children, vaccine for adults, could potentially provide that coverage. We also have new mobile vaccine clinics that could potentially provide some of those vaccinations. When it comes to RSV, even though I know Dr. Staab has already talked about it, most commercial private insurance will provide that coverage, will cover for that vaccine. And if not, definitely this vaccine will be covered by vaccine for children as well as vaccine for adults. Next slide, please. Not to be repetitive, but a lot of the questions that keep coming up are associated with RSV vaccination. The reason for this is because probably these vaccines happen to be a little bit new. There's some hesitation with nirsevimab, just based on the fact that it is a monoclonal antibody. So I think that this table just represents or gives us a really good idea of the coverage of different vaccinations for RSV, 60-year-old and 60 and older individuals. Brisbane can also protect pregnancy, and with Beyfortus, the indication will be for all infants and as well as infants younger than 19 months of age or 24 months of age at high risk. And most of these interventions will decrease potentially up to 75% lower tract respiratory infections that could lead into hospitalizations. Next slide, please. That is it on my end, and I will pass it on to Dr. Price.
That was wonderful. Thank you so much for that statewide overview, Dr. Terriquez, and also for giving us some of the surveillance information and background on what the State Health Department is doing in those spaces. Dr. Price, I'll turn it over to you now. Thank you.
Thank you, and thank you for having me. Next slide, please. I've done some consulting, but we won't be talking about anything about that today. Next, please. So we'll start out with RSV and talk more clinically about kind of what it means for our kids, and then obviously what we can do to try to prevent infection with them. So RSV is mostly a seasonal virus. Usually it shows up kind of January, February, but generally we don't know when it's going to show up, and so it can happen as early as October and as late as March. But with recent COVID, things changed. We can certainly have RSV show up outside the season like we saw a couple of seasons ago. And then places like Florida tends to be a lot longer than that season. But where you are, it kind of will help dictate when you need to start doing prophylaxis. And around here, it tends to be October through March. Next, please. And so, once again, it's a burdensome disease. I know that we've seen some of these stats already, and they might be a little bit different than the other ones that were shown depending on what the source is. The long story short is we have children die from RSV every year, and then there are plenty that have to take the time to go see the doctor, and quite a bit that need to go in and be in the hospital, some of them in the ICU. So it's a pretty big deal for our children, and especially our young children. Next. And then obviously it can certainly affect adults as well. That's not the scope of what I'll be talking about today, but it certainly can be a pretty big problem. And that's why folks have developed the way to prevent that in adults as well. Next. So when we look at who has the higher chance of having severe disease, it's our vulnerable patients, which are our infants, and especially our young infants, and especially our premature infants. Next. And then we look at things that are comorbidities. It's the things that you would expect. People who have a bad immune systems, people who have lung disease problems, people who have neurologic problems where they have a hard time dealing with their secretions and things like that. Next. And then certain ethnicities. So American Indians and Alaska Natives tend to have much more risk of severe disease with RSV. Next. So a couple of options with preventing RSV, and we talk about vaccination and immunization, and it's easy to interchange them and mix them up. And I still have a problem with, trying to stay on task. But when we talk about immunization is preventing infection. You can do passive immunization by giving them the pre-made protection with antibody, like monoclonal antibody. So that's what we're doing with Synagis and Beyfortus. Or next, you can do active immunization, which is vaccination. Next, please. There we go. And then that is where you give them something that stimulates the immune system to produce the protection. And so we have these vaccines that are available for adults, and in particular pregnant people, in order to try to pass that protection on to the adult and then also the baby. Next. One of the problems with RSV vaccines is back in the 1960s, they tried developing a vaccine for infants, and it was catastrophically bad. And what happened is it stimulated the immune system to where it caused an over-exuberant response that actually killed a couple of the babies once they got RSV. And so because of that, people have been really cautious with doing anything as far as preventing RSV in babies. Fortunately, now we have these new things that people have figured out that are safe and effective. Next. So in pregnancy is this vaccine called a Brisvo, and it's really quite effective. And I think Dr. Staab was showing some stats earlier, but basically, long story short is if you vaccinate the pregnant person towards the end of pregnancy, this protection then extends to the baby, and anywhere from 50 to 60 almost a 70% efficacy in preventing hospitalization, but not only hospitalization, but any healthcare visit. And that's fairly long lasting throughout that first season. So it's really this nice option that we have that's brand new. Next. We don't have a ton of real world data yet, and so we'll see how it works out outside of the clinical trials. But right now, it seems like things are looking pretty good. Next. When we look at a passive immunization, the monoclonal antibody, I think a lot of people are familiar with Synagis, or palivizumab is the non-brand name. So this is a monoclonal antibody that's been around for a while, and it was found that it could decrease hospitalization, but it wasn't great for all comers. And so they really narrowed down over the years to really target the higher risk population. And so this was really only available for about 5% of our infants. It did a decent job of preventing hospitalization, but it really didn't do a whole lot else. It didn't prevent infection as a whole. It didn't decrease morbidity. And it was multiple doses that you had to give throughout the season. It was pretty expensive. Next. So it's still an option if nirsevimab or Beyfortus is not available, but really because people are really recognizing that this new medication is superior, they're really focusing on using the other alternative to prevent infection in babies. But if it's not available, it's still an option. But because of, again, you've got a much better option, there's really minimal discussion about when to use Synagis at this point in time. Next. So Beyfortus is the newer one that just got rolled out last year. It's a single dose. It's less expensive than Synagis. Next. It has really good efficacy. So remember, Synagis just had a 50% efficacy in preventing hospitalization in that 5% of babies. This has an across the board almost 80% efficacy of preventing hospitalization. And not only that, prevents any healthcare visit at all for RSV related disease. Next. And in the real world data, there's data like was just shown in the US, and then also in, I believe it's UK and other countries. It's looking like it's working well, like they saw in the clinical trials. Next. So who needs to get the immunization? Right now, it's recommended for all infants under the age of 8 months when they enter into that first RSV season. So remember, October through March is the RSV season. So if you're less than 8 months, at the time that someone shows up, they are able to get this. Now, the exception to this would be, did mom get vaccinated? Because if mom got vaccinated, remember that data is really quite good too. So you don't need to double dip. There are some exceptions to that exception though. If there's a reason where you think that mom was not going to get antibody created and pass the baby, then you could always give the monoclonal antibody to the baby. And so situations would be mom was vaccinated less than 2 weeks before delivery. She's got a bad immune system, things like cardiac bypass, and the baby can remove antibodies and things like that. And those are listed on the sites where you get the recommendations of who should be vaccinated, who should not. Next. The next group then is those high-risk babies in that second RSV season. So that's the 8 to 19 months old who have things like chronic lung disease, immunocompromised, that sort of thing. They can get a second dose of Beyfortus in that going into that second RSV season. Next. It's not recommended if you are a low-risk patient over the age of 8 months, and it's not recommended in the high-risk patients over the age of 20 months. And the CDC is pretty clear right now that that's a hard cutoff. Things may change as time goes on, but that's what they're saying at this point in time. Next. So the AAP and the online Redbook has this really nice algorithm, and it's really easy to quickly see if a patient shows up, do they qualify for RSV prophylaxis? Next. So switching gears, let's talk about influenza. It's also a seasonal virus. Again, the timing and the onsets varies. I know that we've seen some stats there. We can see flu all year, but we get to the point of time where now it's raging in the communities. And we tend to see A before B, but that can happen and go back and forth depending on what's going on. Next. The downside is that we don't have great antiviral therapy for these viruses. We have it, we use it, it's just not great. So really the best strategy is prevention in the first place. Next. So one of the sad things is that, you know, they showed the deaths, and we're up to 200 this last season. 80% of the deaths that happen in children are potentially preventable. They occurred in children that did not get vaccinated. And on top of that, about half of the children that died didn't have any comorbidity. So it's not like you could look at somebody and say, you're high risk. That's why you got it and died. These totally normal children can certainly get it and die for whatever reason. Next. This is just showing there's not a ton of flu activity right now, but it's right around the corner. And the CDC flu view is really helpful if you have questions about influenza, what's going on now, what's going on in your community, what's happening with the vaccine, what about antivirals, all that kind of stuff. And so if you just Google CDC flu view, it'll take you there, and lots of different links with lots of different data about influenza. Next. This just kind of shows over the last couple of years or 4 years or so what's been going on with influenza and deaths. Again, we saw something similar from Dr. Terriquez, but just you can see there right at that first year, right around COVID, when we were social distancing, not a lot of influenza was happening. And now it's back with a vengeance in our communities and children are dying again. Next. So like was mentioned, they surveil, look what's circulating around, and then put that in the next year's flu vaccine and do our best to try to catch up. Influenza changes from time to time, and so it's always a catch-up game. One of the interesting things is the Yamagata strain hasn't been around since COVID, and so instead of having a quadrivalent vaccine, we just or a tetravalent vaccine or a quadrivalent, we now just have a trivalent vaccine. Next. So one of the questions was about, what really, how well does the flu vaccine work? I used to be a bit of a glass half empty person, because if you look at like the 2018 data here, it was only 38% effective in preventing infection against flu A and 50% against flu B. And you look at that, and those are not great numbers, right? And I think we're spoiled by things like MMR and varicella, where you're getting high 90% protection against these for any infection. Well, this is a different thing and a different ballgame, and we're stuck with what we're stuck with. Next. But if you look at what it's really doing, even that not so great vaccine, you're preventing a lot of illness and a lot of severe illness and a lot of deaths. So for example, estimated 10,000 deaths in a year that were prevented by the vaccine. So this vaccine that doesn't work, those are a lot of people that are still with us that otherwise would have been dead. And some of these are children. Some of these are children's caregivers. There are friends, people that we would rather still have with us are still with us because of this not great vaccine. And there's a lot of time that people aren't wasting with going to the doctor or going on their vacation or doing whatever it is they want to do real life that's not being affected by influenza because of this not great vaccine. Next. So the other nice thing is that with this vaccine, if you have been vaccinated and get influenza, you are less likely to have severe disease compared to someone who didn't get vaccinated. So there's data in children that they have decreased rates of mechanical ventilation, vasopressor use, and ICU admission if they've gotten vaccinated and still had breakthrough infection. So again, not a great vaccine in what we'd like to have, but there's still a real benefit there. Next. So the options, there's inactivated, and they are active. And why don't you just kind of keep going through until we're at the end of the slide here. But you've got your egg-grown vaccines. There are some adjuvanted options and high-dose options for adults. Go ahead and do next. You've got some cell culture options. Next. And a live attenuated. Next. And a recombinant. So one of the things is that, with the egg-based ones, people used to worry about egg allergy. That's no longer an issue with all the experience that's been out there. If you even have anaphylaxis to egg, you can still get influenza vaccines that are egg-based. So there's no longer a recommendation to watch people or do any testing or anything like that. Obviously, if you've had an anaphylactic reaction or a severe allergic reaction to a component of the flu vaccine, you're not going to get the flu vaccine again. But as far as egg goes, that's not a contraindication at this point in time. The live attenuated is, for a certain range of patients, and there's some contraindications there. The FDA actually just approved its administration at home. We'll see what the ACIP has to say and what the CDC says as far as recommendations go, but haven't heard anything about that yet. But it's an attractive option to get vaccines out to people that may not have great access or the time to come to the doctor to get that. The interesting thing, the flu block, that's an 18 and older only drug or vaccine. It's actually got a needleless injection system. So if you've got people who are scared of needles, that might be an option for an adult. Next. So everybody over the age of 6 months should get vaccinated, unless, again, there's a contraindication, and those are very few and far between. Next. And now we're getting into the flu season. So the recommendation is to go ahead and start now. And anytime somebody shows up during the flu season, go ahead and vaccinate them. In high-risk adults, there's this question about timing, but that's a different discussion for a different day. But there are options there. Next. And this is just showing that, again, or switching gears now to COVID, that COVID's here, it's here to stay, and it affects all patients, including children. Children tend to do, have less severe disease compared to adults, but like Dr. Terriquez showed, it can be pretty severe and cause problems. Next. So there's lots of variants out there, like flu. I suspect we'll be playing catch up as time goes on. Every time you turn around, there's another variant, but it's just the nature of this virus. Next. So when we're looking at vaccinating children, there is benefit. First off, you can decrease the severity in the child themselves. You may decrease some of these, post-infectious issues like long COVID and MIS-C, and then you can also decrease transmission rates to others. Kind of like flu, it's not great at preventing all disease at this point, or all infection at this point in time, but it does a pretty decent job of preventing severe disease. Next. There, certainly was discussion about risk of vaccination. One of the major things that people saw was myocarditis. The good news is that this is very rare, and it's really rather mild for the most part. And this was after mRNA vaccines. And so most cases that people saw lasted a day or two. They just needed some NSAIDs. Some of them got hospitalized. Almost all of them got completely better right away. And right now, still, the risk of getting myocarditis is more likely with the disease itself than it is with the vaccine. So these really are very safe vaccines as far as giving to children. So if someone is coming in really worried about the COVID vaccine causing trouble to their children, I get it. It's this discussion you're going to have, and it's a good discussion to have, but it's probably not the thing they should be worrying about at that time. Again, you totally need to talk about it, and it's a good long conversation to have, but it's not the problem that's probably going to happen to their child. Next. So looking at what options there are, there's 2 mRNA vaccines, and there's the Novavax, which is the subunit vaccine. They're different strains that have been recently circulating that they're based off of. And this is the most updated option, is these monovalent vaccines that we have for 2024, 2025 that just got approved and are being rolled out at this point in time. Next. So there are, different schedules depending on, how old you are and which dose you get. It's that youngest group of 6 months to 4 years of age. You're getting 2 or 3 doses for that baseline vaccine. If you're older than that, you're just getting a single dose if you're the mRNA vaccines. If you've had prior vaccination, then you're going to either get a single dose to update or a couple of doses depending on where you are in that primary vaccine schedule. The CDC has a nice document that shows you exactly what to do depending on how many vaccines you've received and where you are at this point in time. And then if you are immune compromised, usually you get an extra dose. Next. So that's all I got for now. These are some references of some articles that may be helpful with answering some more questions, and happy to answer any questions too.
Thank you so much, Dr. Price. That was great. At this time, we invite you all to put any questions that you have in the Q&A, and we can start going through those. But to kick us off, I'll just ask a couple of questions to you all too. So Dr. Staab, you talked about renormalizing vaccination by talking about why you get vaccinated instead of talking about why others should get vaccinated. I'm interested across this whole panel, if you all would share any other strategies that you want to highlight that you found to be successful in encouraging folks to get vaccinated, particularly when it comes to these winter respiratory diseases.
I'll reiterate what I heard Dr. Price say, and I think focusing on not wanting illness to interfere with your routines, right? And we're getting ready to go into the holidays. A lot of people have travel planned. Whether you're traveling or staying locally, it's very likely that you'll get these infections, especially if you're not vaccinated. So I think it's a nice way to just kind of say, prepare not just for the respiratory season, virus season, which is not all that exciting, but we all get excited about holidays. None of us want our kids to be missing school this year. So if you've got kids in your families, I think that's a good way to make it work too. So that's usually what I go to.
Yeah, I agree with that. I think that, and not to be sentimental, but we know how bad it gets. And I think that the way that I usually promote vaccination, especially for those individuals that are hesitant, I just let them know, like, I mean, sure enough, you may not want to do it for yourself, but we all have loved ones. We all have grandma that may have uncontrolled diabetes. We all have our other relative that may have some other immunosuppression. So do it for them. I think that that's a good approach to do it for your loved ones.
And I like, just like Dr. Staab said, it's just normalize it, make it normal. Don't tiptoe around it. Just go right to it. This is what we do. This is what we know works. It works really well. Yes, there are some risks. We can talk about those if you're worried about them, but just this is standard. This is what science has given us and experience has shown works really well. I've got 4 kids of my own. I tell them often, I have no problem giving my children these vaccines, and I've already given them to them, or I've got the appointment scheduled for this season to do it. And so hopefully that, helps them see I'm a real person. I think about these things too. And I'm not going to put my kids at risk for something that's risky just because I'm trying to line my own pockets or whatever, people want to worry about.
That's helpful. Thank you all. Another question that comes up, not related to vaccine hesitancy, but more on the provider side, guidelines, recommendations. Actually, I guess I hear this from the public too, but there's a lot of questions that arise around timing of COVID vaccines. And we've seen a lot of changes in the COVID vaccine recommendations recently, like how frequently you should get them, if you've been recently infected, how long should you wait, what variants are covered. What is the best way to stay up to date on the changing recommendations, and both from a member of the public, but also on the provider side?
So CDC does a really good job of updating things. There are some parts of their documentation that's older and not updated, but the really important stuff, they do a good job. So whenever anybody asks me this question, I usually go there first and see, is it there, and can I find the answer quickly? The thing I like to explain to people though is that this is a lot like influenza, that it's here to stay, it's changing all the time. So we've gotten used to, we have to play catch up with influenza. I think we're going to have to do that with COVID for a while, if not forever. And just also reemphasizing that since it's changing, science is really on top of trying to track down those changes. And so the fact that we are changing with it is a good thing, because sometimes people worry about that, right? Like, hey, what you told me today is different what I got told yesterday. Well, that's a good thing. We have new information to help us tell you better at this point in time. And no, it may change, tomorrow or the next day, but we're trying to do our best to keep up to date.
I'll just add, Jessica, I think normalizing it to our, how we treat the flu vaccine is definitely the direction I want to take things. I'm hopeful that someday we can get a combination vaccine with both together so that we can make it that much easier for folks. I think while COVID is here to stay and it's definitely kind of become what we're terming endemic, I think there's still some patterns where we see, the summer surge, and for those particularly high-risk groups, I think there's still a couple of years where there may be recommendations for this kind of off-season boosting for those high-risk folks. But for the general population, starting to think about it, and for us as providers to approach it like we do the flu vaccine, is definitely the direction I'm trying to take things.
Thank you. And you mentioned potential combination vaccines in the future, like a flu COVID combination. I know it's come up through your presentations as well with the recent FDA approval of self-administered vaccines, and waiting to hear what APIC has to say about that. What do you all see as up and coming in viral respiratory prevention, or any comments on some of these newer formulations or administration methods that are near term?
I'll say I don't have a crystal ball, and it's certainly not my area of expertise, but looking at that pipeline of where development is, my kids asked if they can get the two vaccines together, and I said, sure, you can get them at the same time. So I think it's just reframing kind of expectations. Again, it's not, there have been a lot of questions about how many vaccines, is it safe to get at once? I think the provider community generally understands that it's safe to get multiple vaccines at once, and it's good from a scheduling standpoint. But I think the more options there are, so there's a question in the Q&A here about what we think about the newly approved at-home flu mist. I was kind of surprised by that because I didn't see the need for that, but I think what Dr. Price said is true. The more options there are for people, if they're having a hard time accessing vaccines through traditional routes, the more options we have out there, the better. So I think it's a fine line between things being confusing versus easier, but I hope that we're getting towards easier and more acceptable.
Yeah, I agree with that. I think that as time goes on, more and more is being learned about different viral structures. So I definitely see more, and I may or may not have a crystal ball, but I definitely see probably different targets. Maybe some of those targets that may be associated with less of a risk or less of a potential for side effects. But definitely more information to come regarding different target sites for different vaccinations. So I think that's where I would like this to go, minimizing the possibility for side effects. Again, side effects as it is right now, they're very local, they're very minimum. So I'm not horribly concerned, but I know that some patients are concerned about those. Definitely, there's a lot of research regarding the remote possibility of, let's say, myocarditis associated with the vaccine, which has been proven that it's probably comparable, if not similar, to just the risk of myocarditis due to the infection. So I totally see us exploring different target sites to develop new new vaccine technology.
And I think we live in a really exciting time. I really feel like if these numbers are correct and sustainable for RSV prevention, this is going to revolutionize our respiratory season, because we see lots of babies in the hospital and ICUs and things like that. I bet the people that are in the clinic, most of their day is probably spent with respiratory viruses in the middle of the respiratory season. I think this is going to really, really change what we do and how we spend our time.
Jessica, can I make one addition? So I see a couple of questions in here about addressing issues with the public and kind of how to change the way we're talking about this. And I think another effective way is to remind the entire community that our healthcare system does have limited resources. So the door, while it's always open, how long that line is inside the door changes a lot during the respiratory season. The more we can prevent people from having severe infections with respiratory illness and needing to access the healthcare system, the greater access we have during those months for everything else that people need with healthcare. And boy, we sure saw that stressed with COVID-19. So I think just taking people back to that kind of highlights the role that we all play, protecting each other as a community.
Well, thank you. On that note, I think we'll wrap it up on protecting each other as a community. I like that as an ending statement. So Dr. Staab, thank you for that. Dr. Price, Dr. Terriquez, Dr. Staab, thank you so much for your insights today. For all our attendees, we really appreciated having you all here, and you can check the NARBA Institute website in the next couple of days. You'll see the slides posted there, so you can check all those out as well. Also, please mark your calendar. Our November community grand rounds are coming up on November 6th from 12 to 1, and we'll be focusing on diabetes and diabetes prevention, as November is Diabetes Awareness Month. With that, I will close by once again wishing you all well. Please stay healthy. And Drs. Price, Staab, and Terriquez, thank you so much for your insights today. We hope you all enjoy your week. Thank you.
Thank you so much.
Thank you.